Hello, good morning,
Good morning.
good afternoon for you.
Antonio, this is Gary. I'm here with Ajay Kirkney. Yeah, I pretend that I'm Marty. Marty never made it here because of visa
Okay.
issues. So you can call me Marty. That'll be fine.
Okay, I call you Matt. Okay, but it's always a real pleasure to be with friends and to transmit again to India. I send the picture to Sushil, and you should have the case presentation, but Alaide Chieffo, which is on my right side, will summarize this case. Charbel is helping us, and Tadashi is doing the IBUS. This is called BVS, diffuse disease of the LAD. Please.
Okay. So first of all, good afternoon to everybody. This is a 60-year-old gentleman that came to our attention for progressive worsening of class 2 stable angina. His risk factor were to be non-insulin dependent diabetic, to have dyslipidemia, hypertension, smoker. The only risk factor actually he did not have was family history for coronary artery disease. At the coronary angiography, the patient had severe 3-vessel disease involving also the left main. Aeroscore 2 was quite low, and syntax score was 36.
So here you should tell me if you see there is a baseline RAO projection. Do you see it?
Yes, we see it.
So there is some distal left main disease of the OM, and diffuse disease proximal LAD with suboccluded mid-distal. Possiamo andare alla prossima? It's a little bit another same RAO. Next.
Craniale.
This is a cranial. This is a little bit worse representation. Real diffuse disease of the LAD, too big diagonal or relatively big, medium-sized diagonal. So this, it's a good surgeon, of course, can take care with the sequential mammary, but it's not an easy case for surgery, but it's not also an easy case for PCI. So what your impression first?
Antonio, it's Sushil. My impression is the same as when you sent me the case, and it looks crazy, but the point you raised is an important one. I mean, in terms of sending this person, what are the options? If you send this person to surgery, there really aren't great options. And so it's a fascinating case, and the question is, how do you reconstruct that whole LAD? And in the era of BVS, is the paradigm different, and what are the options?
So what we did, we have a 7 French guide, 7 French because we have to work with multiple wire. Even without BVS, 7 French, when you work with multiple wire is okay. We went femoral. We used an over-the-wire 025 with a universal, La Prossima.
Okay, so the first thing, Antonio.
We arrived, yeah.
So you went femoral. I was informed that India is about 110% radial. So
I would have no problems to go radial.
Okay.
The only reason why I went femoral, I feel I'm an old-fashioned guy, and I feel more confident with femoral. I learned radial at a late age, so I don't feel comfortable and relaxed as someone who learns radial at a young age.
Right.
So that's the only problem related to the operator.
Yeah, you and I are in the same position.
Antonio,
I think someone's smiling next to you, Antonio, though.
Yeah, Alaid is like laughing at us right now.
Yeah,
I'm
because
not-
they are a
I'm
little
smiling.
bit age advantage. What can we do?
No, but you use the 7 French guiding catheters. So
Yeah,
maybe
but
this could be,
you could have done with the 6 French. The only thing that I don't like about the 6 French, if I'm using 3 wires, as I'm doing here, the IVUS is a little bit tight. Goes, but you have to struggle. With the 7 French, it's a little bit easier. Let's go to, we stopped here with the universal, so we switched to a filter FC, and the filter really went down distally without much problem. Then we pre-dilated with a 2.5 and with a 2.0. Here is a 2.0 semi-compliant 30 millimeter, inflated at various level. Next. Expanded reasonably well. We start seeing some flow. There is some dissection. We went with a 2.5 semi-compliant. It's interesting that when we inflated the balloon distally has some pain due to stretching. Here you see considerable dissection, which means that you are preparing the vessel. Next. Several inflation up to 20 atmospheres with a 2.5 non-compliant there. And at the bend where the LAD dips down, we use a 3.0 non-compliant, 20 atmosphere, and very, very proximal with a 3.5. So
Did you,
this
Antonio,
is
did you,
one of the last.
before you dilated
Yeah.
distally with the balloon, did you IVUS it to see the size first before going high
Yes,
pressure?
yes, that's a very important question. That's exactly what we did. After we went with the 2.0, which was needed to make room for the IVUS catheter, the IVUS went distally, and Tadashi is going to show you the IVUS right before the 2.5. Your point is well taken, and that's what we did.
Okay, I'll show you IVUS image following 2.0 pre-dilatation. Here is a very distal LED. The lumen diameter is 2.2 by 2.4.
So very, very distal, it's not even 2.5,
Okay.
but we are talking quite distally.
And more proximal, we can see the.
So this is the
the
distal
vessel.
to the bend, maybe 3 fingers distal to the bend.
Yes. Here we can see the vessel diameter 2.28 by 3.0. And here second diagonal comes from 4 o'clock. And here is a lesion between second diagonal and first diagonal.
And here is a big 3.0, maybe even more.
Yes, very big vessel.
So here we dilated, pre-dilated with a 3.0 at 24 atmosphere, non-compliant.
Okay. Then here we can see the first diagonal comes from 4 o'clock. And also here we can see the very big vessel, 3.8 by 4.5.
So approximately 3.5. And we don't have a recording of the left main, but the left main is more than 4 millimeter. So if we place a stent on the left main, we may have to use a metal stent. So let's see, we are ready to implant the stent. Can we show, andiamo avanti ancora un po'? We show you next, this is the IVUS. After the IVUS, we dilated more aggressively to 5 high pressure, we didn't do before. This is a 3.0 at 20, and here is after pre-dilatation. The first diagonal is not great, so we went with a 2.0 balloon next in the first diagonal, did a couple of inflations. We would like to be provisional. If we have to do double stenting, we are going to use a tap or a mini crash with a meta stent on the diagonal. The diagonal is too small, too much diffuse disease. For the current generation of BVS is no good. But we can do an hybrid. This is a the last shot taken 5 minutes ago. So you see a considerable amount of dissections, double rail everywhere. And this is a real poor man IVUS. If you do QCA on the double rail, you get some vessel size.
Antonio, we thought you were a gentle person by nature, but I think for these preparation of these lesions, you have to be a little bit aggressive, huh?
Yeah, but you know, this is most probably what you have to do also for DS when you have this diffuse disease. So we are ready for the first stent. We will use a 28 and we try to go as distal as we can. We'll use a 28 2.5, but the nurse told me that we have to use the 18 because it's expiring August 16. So we are going to go very distally with an 18 because we have to be cost effective and otherwise we have to throw it away. And in Italy this week is a very slow week. It took no time to come from my house to the hospital. Normally what I do in 45 minutes, it took 20 minutes, maybe less.
Yeah. There is nobody.
Okay, so this is a 2.5 28 BVS.
18.
18, I'm sorry. And I'm going down on the LED wire. We have not done any additional pre-dilatation. I hope we don't get a lot of recoil. It's going down reasonably well. There I have resistance, so I engage my guide and I maintain a constant push. I don't do this jiggling, just constant push. And goes. Tagashi, will you go more distally? I think I will go a little bit more distally.
Yeah.
I know that there the vessel maybe is too far. Let's take a nice test. Pronti, strong. I think it's okay. If we needed to implant an additional stent, I will go with a metal 225. Do you agree?
Yeah. Looks good. Anton, did you consider debulking with or rotational atherectomy at all in this type of diffuse disease?
Yeah, I consider we can start inflating two atmosphere. I consider, but the plan was let's be traditional. If we have any difficulty to go with a balloon, we're not going to use body wire, body stuff. We're going to go with a rotablator. But the balloon went down without much difficulties. So we are at 2, 3, 4, slowly, stay at 4.
Antonio, you're planning to put multiple BVSs in that LAD. So what is your strategy for the overlap? Do you just keep it marker to marker and overlap?
I just I put the balloon marker of the next BVS on top of the platinum marker of the just deployed BVS. Go to 5. You get a lot of preconditioning when you do these procedures. 5, 6. Very boring procedure, long.
So talk why, if
6,
it's boring, why don't you say
7.
something? So Antonio,
Yeah, for example,
I was curious about the possibility you mentioned, if I understood correctly, of combining BVS and conventional metallic DES. I guess I'm sitting here trying to understand if that makes sense.
I mean, theoretically it does not make sense, but for practical reasons, the vessel is very small distally. So to place a 2.5 BVS, it will be under-deployed, a lot of foreign body in a small vessel, 150 micron, 23% coverage compared to 12%, and 80 or 90 micron, we are 8, 9. So I usually don't go at high pressure with this balloon. You see, the stent is under-deployed in the center, and needs post-dilatation with a 2.5. Let's go to 10.
At least 10.
Needs a post-dilatation with 2.5. If we keep on going up with pressure, we just gonna dog bone. Is no good. So this next extra work, we're gonna go back with a 2.5 non-compliant at 20 atmospheres inside the stent, even before doing AVUS. I already know that it's clearly under-deployed in the center, needs work.
So
Okay,
down.
negative.
But
But to go back to the point that Gary raised, for example, for these medium-sized diagonal, smallish, I mean, we did implant BVS, but to do a T, sometimes you miss the ostium. Inflate, let's inflate just to make sure that we have room for the next one.
but what about drug-eluting
10.
balloon? What do you think?
Oh yeah, drug-eluting
Could
balloon
be a solution,
for
no?
these diagonal go to 12. We just prepare for the other in case we got recoil negative.
And distal LED, if it's so small,
Drug-eluting
balloon
balloon.
could be
we
an
have
option, huh?
we have a 225 drug-eluting balloon. Unless you have a very, let's go to 10, 12, 14. This is a 2.5 semi-compliant, no much because. Okay, I think we can go down. So let's take a picture just to see. And please, Alaide, Charbel, you young people have a better eyes than me. Make sure that you see the markers, because the markers are not so easy to be seen. Okay, let's take a picture. This is the LED wire. Pronti?
okay. Yes, you can see, no?
Ma-
Where there is that very small diagonal.
You see the marker?
Yes.
Let me see.
That's my
Yeah, I see
my
the
LASIK.
marker. I see the marker. Okay, we definitely need the stent proximally, so we can go with a 2.5, 28, mi dà il 2.5, 28. C'è qualcuno? Ah, grazie. 2.5, 28. So this is going to be, and again, I would have taken the 228, the 28 from the beginning, but we needed to use this 2.5. I think we're going to end up 1, 2, 3, another
least.
328 at least. And I think for the left main, we have to go for the hybrid due to sizing issue. And it's not easy to make a 2.5 BVS with current technology, a 4.0 BVS, sorry. So this is mounted on this protective, can you you just take out these, and this is a stent, there is nothing particular. And if it doesn't go, you take it out, you predilate better. They say that you should not leave it out too long. There is not a time limit by science, by technology, but it's usually half an hour maximum. And then after half an hour, you lose retention. So let's hope this goes down. So I see the mark. A little bit of resistance there, so I get some guide. Continuous push. Let me, while I'm here, Let me get my diagonal wire a little bit better, and the other one, I don't wanna, okay. I need to go down another 5 millimeter, so continuous push.
I think it's here.
So just,
Possiamo
just
mettere
constant
maximum
pressure though,
zoom?
no hammering or anything like that.
No
just,
jiggling, no.
Here it is. This is the marker.
Yeah,
This is
so
the marker.
I'm senza contrasto.
Yeah, this is the you see
So
the marker?
you see the balloon marker is on top of the platinum mark. I could come back a little, but let's go like this, because it's really a lot of dissection. Even if we have a small overlap, is okay.
Yeah, it's 0.5.
Okay, let's go to 2. So the platinum marker is not exactly at the end of the stand. There is a little bit like a half a millimeter, 0.3, 0.5 plastic. So 3, 4. You have to inflate slowly. They say 1 atmosphere every 3 seconds.
Antonio, what happens once you come to the proximal area and if you don't find the right length for a suitable overlap?
But here I have tolerance, because I can finish any place. If I'm really tight and I have to finish exactly in one spot, I have to start from proximal to distal. It's a little bit more demanding, because sometimes, for example, if you start from proximal to distal, you always have to post-dilate each stent before going with the next. Here, I can afford to do a final post-dilatation. How many?
8.
8, 9. Here, I think we can go with the trio. What do you think?
I think
Yeah,
so.
we can go, because we dilated. Ci prepara un 3,028. Ce ne porta 2 di 3,028 e un 3,5 28. So we get 2,3028. And I mean, if you really want to be ultra precise, let's say that we said we're gonna be precise on the ostium of the LAD, then we have to start from proximal to distal.
Yeah.
Here I have deboarding a little bit in the left main. It's okay, I'm gonna post-dilate 4, and if you are really very patient and inflate very slowly, you can even go a little bit 4.2, 4, but you have to inflate very, very slowly. How much?
10.
10. Let's go to 10. Okay, we have to post-dilate anyway. Down. See, it's a lot of work, because now you have play the other and then post-dilatation. And you know, we started this case at 8:30, so we did not have any problem. Everything went smooth. So 8:30, 9:30, 10:30 is already 2 hours. Okay, let's take a picture. Sì,
Non lo prendere, guarda.
aspetti un momento che tolgo, I remove the balloon. You want to go in cranial? Let's go in cranial. It looks a little bit more photogenic. Andiamo nella craniata. Sì.
Vai.
Okay, so, yeah, okay. So we did not reach the first diagonal, the second diagonal. Pronti? Yeah.
Si vede bene.
So
si vede il marker,
I
lo
see
vede
the marker,
dove è più
and
settato.
you see that we really need to post-dilate. I mean, we could, what do you think to post-dilate? Now I see that proximally, I will go to post-dilate before
okay.
implanting the stent. No? Or we can do it after.
we can do.
We can do it
Honestly.
after, it's okay.
I would do.
Okay,
Here we have.
let's do it after. But the proximal part is still under-expanded.
Yeah. Where is the
Now,
marker?
But the
overlapping
marker is
It's
there.
exactly
You see,
there. It's
the overlap is to have minimal or even no overlap.
it's protruding,
If
protrusion.
you
ecco.
leave a little gap, it's okay. So this is a 3028.
Okay, here it is.
Ok, you see the marker there? Possiamo
Yes.
andare a 15? No, non ho the atmosphere.
No,
field.
I know.
Ok,
Never.
no zoom. Do you see the marker?
Yes.
Do you see
Yeah.
the marker?
I
Are
see.
we okay?
Yeah. Here it is. Sta là.
Yeah,
Here it is,
exactly.
exactly parallel.
Perfetto.
You don't see
Balloon marker is on the top of the platinum. Let's go up. Possiamo tornare a 20. And of course this diagonal is going to be provisional. And we jail the wire, no problem. And if we have to rescue this diagonal, we do traditional. We go with the balloon. We don't like to go on the side branch more than 2.5. John Ormiston has done a beautiful bench work. I hope it's going to be published soon. But if you go to 2.5 maximum, you're not going to break the link. More than 2.5, you may break some link. Usually, to break the supporting struts, you have to be more aggressive. If you break some link, it's not the end of the world. It's okay. How much?
7.
Antonio, are you concerned about the side branch wire when you're going on high pressure in the stent?
No, we do it exactly the same as we stent. 10, 9, 10.
Okay.
Come va? Tutto bene? Okay, he has some occasional pain, but not so bad. 10.
Reare. 10.
Okay. Can go to 11. This is a semi-compliant, should not really go to very high pressure.
Then when you pull the wire out after it's
11.
jailed, have you seen either via OCT or otherwise any deformity of the stent or no?
No, but I've done it several times. Go to 12. Oh, and I even leave the wire until I'm done with post-dilatation. Negative. I
definitely
like to
saves
go a
a step.
little bit distal. I like to go a little bit distal. So this balloon is a trio balloon, and the distal stent is a 2.5. Flat a little bit, but so you have to go very slowly here.
Yeah, because you are
Let's go to 2. Because we are overstretching the distal stent. 2, 3. I have to go with the semi-compliant anyway, but because of the dent that there was, I like to take care a little bit. 3, 4. 5. See, I think the distal needs some work.
Yeah, I think non-compliant balloon.
6. See how unexpanded? 6. 7. It's not well prepared, but still the
it's not
distal is
open.
not 7, 8. 9.
Is your
You see how
point,
the balloon opens and yeah.
in all of these BVS cases in general, do you always post-dilate with a non-compliant at the end, or not necessarily, these long BVS?
Personally, personally almost always. 10. So you see that the distal needs work. There is a lot
Yeah,
of
with the
air, but still,
non-compliant, no? We can go with the
and you
non-compliant.
see how badly conforms the non-compliant, dilates where should dilate down. So over there we're going to go first with the 2.5 very high pressure, but then let's finish the work. Or we can do it, you want to do it now? Let's do it now, because I want to make sure that I have good runoff. Mi dà il 2,5 non compliante. I think we have it. It's a little bit beaten up. Maybe we take a new one.
I think a
Mi
new
apre
one,
uno
because
nuovo.
we used several
Because
times.
I
so don't
really
know.
inflated this non-compliant balloon 20 times. So we take, let's take a 2,5 let's take a film just, it has a good creatine, so we can afford.
Good.
You know, it's a little bit better. It looks
great.
from the time he came.
It's great.
I mean, it's much more presentable.
Much more photogenic, as you said.
No, it would have been fine.
Yeah,
We kept you waiting,
Cosmetic.
so that's why.
But I want to pause dilate now to make sure that I have a good runoff, and I mean, it's something that I have to do anyway, but that spot, I think we're going to go up.
So it looks like
And
it's
we
primarily that
implanted the
spot.
2.5 stent.
How high
But
have
I
you
will
gone
go
with the
first in that.
post-dilatation with the BVS? Do you have the same mentality as with DES? Or?
Yeah, let's go to 10. I went, there are some spot where we had no good expansion, and we had to use this special Swiss balloon that goes up to 38 atmosphere.
20
Yeah,
up, I think.
20, 22,
It's not open. Okay.
24. You see, it's not expanded well. We are at
Want to go to-
24. Let's stay up 26. You see that despite all the dissection we had, in that area we don't have good expansion. You see, we are at 26.
Yeah. So just to point out for the audience, Antonio, you do not consider this great expansion of the balloon, correct?
No, you see, it's very obvious that there is one spot.
Right.
Look,
I mean, so when you want, if you say full expansion,
Yeah.
the balloon has to be fully expanded, more like a hot dog than
Yeah.
like this. And a lot of people think that this is good enough.
Or you will see, I am not sure that we'll have time to do it, but we have to try. But this is going to be not good. I don't know what to do. I am at 29. I don't want to break this balloon. This balloon is not certified. So,
Maybe at
this,
the end we
it's
can go
okay,
to
it's a
30.
limitation. What can we do? If we don't have in San Raffaele, andiamo in obliqua destra, we don't have in San Raffaele the CIS balloon. Is the one from CIS Medical.
Right.
It's a non-compliant balloon, certified up, dov'è il distal marker?
Più su. Là, un po' più su. A little bit up.
But Antonio, the
Yeah,
reason
the
that Gary
we have
mentioned
another
that
mark.
Yeah. You mean the distal?
The distal.
Distal is down. Is here. Here it is. No.
Here?
I think you're right.
is that the utilization of IVUS here in India is quite low, and I think that your
Down,
way of
down,
seeing the
you see?
angiogram changes
Okay.
when
yeah.
you've seen what the IVUS looks like,
Yeah.
and so that's why I think it's
Yeah, let's
important
go
to go
up
up to
to-
those types of pressures.
10. So these are very distal, 10, 12, 14. You see there is a spot that is not perfect. 14, 16.
Is there a role for
18.
shorter balloons when you're going this high and in this distal? Do you have any concern? I know it's non-compliant, but do you have concern with the longer balloon?
Not really. The longer balloon tends to break more easy, 20. I think over there we stop at 20, we are quite
Yeah.
distal.
I think so. We go down.
Negative. You see how much preconditioning and
Yeah.
is very good for creatinine, contrast nephropathy. Let's go up. There is a nice paper in circulation, the value of preconditioning to prevent. So in this view, the balloon
20.
is not so bad. Go to 20, 22. So it's most probably very eccentric.
Yes.
25, which is okay. If it's very eccentric, maybe the IVUS lumen as a cross-sectional area may not be so bad. But definitely you see that there is a spot near the marker that is not down. Let's do again up there. So let's go back, andiamo nella craniata. We are ready to implant the third long stent.
20.
L'ha già aperto lo stent? No. Tadashi, do you think from there we can go with 3.5 or 3.0?
Yeah, we can go 3.5 with no hesitation.
3.5.
Yeah.
Let's take a picture. So the marker of the stent, I can see the marker. So the marker is right there where I have the distal balloon marker. Let's take a picture so we get an idea. Yeah, with the balloon there, via. Yeah, I think we can go with the 3.5. So we're gonna go with the 3.5/28, and then we decide.
Okay.
And this patient is going to be on prasugrel or
5.28,
ticagrelor
Absol.
for at least 6 months, because with this huge amount of foreign body, no matter if he's bioreabsorbable, he needs 3,5,
Sì, 28.
3,5, perfetto. 3.5/28. We give, and the follow-up, you can do multi-slice CT very well. But again, if I had here the very high pressure balloon, I will go with a 2.5 at 38 atmospheres.
because there
You
is-
may not succeed. The point is, should you do in this diffuse disease routinely rotational atherectomy, no matter what, because we did not see this under-expansion on pre-dilatation. And with that nice dissection, you said almost sure that the artery was well prepared, but focally. So now, so we already post-dilated the distal stuff.
Yeah.
So there is no need to trap these diagonal wire
Sure.
so aggressively in under 2 stents.
Yeah, unless
So-
you don't want to post-dilate further the distal LED.
Yeah, but I
Because
think
it's still a little bit underexpanded.
yeah, but we went to
Okay.
30. There's no much
Okay.
we can do. So which is the distal wire? The one with the
Should
torque?
be the one with the torque.
Let's
let's
see.
check.
So let's check the one without.
Antonio, this is also an issue for true ostial LAD lesions. You can't sometimes make out whether
Here
the
it is.
balloon is fully dilated, the lesion. And so,
Yeah.
at least in my practice, when I'm using BVS for ostium of the LAD, I use always a cutting balloon, just to be absolutely sure.
Oh, yeah, that's that makes sense. I mean, everything you can do.
Down, I think. Sì.
Let's get this wire a little bit came out. Okay. Are we okay? I think we are
I
okay.
think so. If you want
Okay.
to-
Inflate slowly.
Do you want to do a check?
No, I think it's okay.
So, Antonio,
I don't know, this is, yeah,
I mean, I know it's,
Two.
this will be a hard question to answer, but suppose you were using metallic DES. Do you think you'd be getting better
Yeah.
expansion?
no,
think
I think
some-
the expansion is going to be the same.
You think it'll be the same?
Because I think it's the same, because unless, I mean, I did not do any testing myself. The people from Abbott tell you that the radial force of this stent is very comparable to science. See, a lot of ECG changes now.
diagonal.
And the acute plastic deformation is also the same?
They say yes.
Okay.
But after, you see, here is suffering.
I think it's diagonal.
I mean, I think we were just both commenting, I
So,
was commenting here as
Sushil,
well. Oh.
I am supposed to give a lecture, but don't you think it's better to stay with the case?
Agreed, yeah. I think everyone would be interested to see this case.
Yeah. I can send you the lecture by internet.
I'm sure it would have been fascinating.
I'm going, so now what I'm going to do, I'm going to post-dilate proximally, we take a nice angio, and then we go with IVUS.
Yes.
Yeah,
We
Sushil
even
and I were
have
just
OCT.
Sushil and I were just
But,
saying
I
that
don't know
because
if
of the
we have
blood pressure
time,
and
yeah.
everything else, this may be an issue limitation. That's why you're taking the metallic, right? Because of the blood pressure and the time you'd have to inflate.
No,
it
no, I'm
with the
taking
size.
the metallic, I'm taking the metallic because of the size.
The vessel
length,
size,
size.
because it's a very big left main. Okay, this is the mark.
The marker, yeah.
Yes.
Let's go to, so this is the 3.5, we can go to 10, because our base camp was 10.
Yeah.
So from the base camp of 10, we go up slowly. 12,
14,
14,
16,
16,
Convenient either way.
You know,
15.
plus, Ajay, you know, the
20.
statistically, the restenosis rate in a left main
Sì.
treated with a DES with good expansion is
20, yeah.
extraordinarily low.
Yeah, no,
You know, lower than probably diffuse lung disease.
But it goes back to one of the question you asked earlier, Gary, the issue of overlapping metal and
Up.
Well,
BVS.
it's not just overlapping, it's you use BVS so that the stent dissolves and you restore normal function. So you've got a segment that's normally, that you hopefully restore normal function, adjacent to a segment with a metallic device. So exactly how does the
quanto
hybrid
siamo?
work, and have you,
10, 12,
what's the benefit?
Lascio il 3-0.
Other than the fact that,
14.
you know, if you at some point need to put in a mammary, you've got a clear artery.
Do you believe any of this stuff in terms of, they were saying between 1 and 2 years, potentially growth of the vessel that they
Yeah.
showed in something? So then do you think the
No.
stent will be pulled away or?
Could be.
test.
And so, okay.
Could be.
I mean, but we were talking about that before. Isn't it already maximally
No, perché c'è il
positively
pallone
remodeled to
ancora.
some
Prova a
extent?
fare un
But
gonfiaggio di solo a 6.
I mean, the data, the serial OCT and IVUS data that comes out of Patrick's laboratory suggests that
Okay,
as
negativo.
the BVS reaches the end of its existence, if you will, the vessel returns to normal reactivity and in fact grows.
Yeah.
You know, and the growth is in the 12 to 18 month to 24 month range.
Per l'anno.
So
we
in
are ready,
theory,
let's do. Pronti?
so in theory,
Gary, sorry to
no, sorry.
sorry for the interruption. We did the post-dilatation proximally up to 20, 3.5 non-compliant, and we are ready to take a picture. Blood pressure is fine, ECG is fine. Ready?
Oh, that's good.
Pretty good.
So the second diagonal is a little bit suffering. You see there is
Yes,
this,
still that area
this
is
area.
not expanded. Or we go.
Let's go to the RAO. The septal are okay. There is a reasonable septal perfusion. Pronti? Mi prepara per favore un arinato?
That's good.
Not bad, eh? I mean, if you consider how this guy came in.
Yeah, absolutely.
I think, andiamo indietro, what I'm going to do IVUS because
Yeah,
it's more
let's see.
important. Sì, no, solo far vedere. But what I will do maybe off camera, no, la craniale.
Okay, so back to
Okay,
your...
what I will do, I will recross into the
diagonal.
second diagonal, but I will do, first I want to do IVUS to show
Yes,
the area of
to be
under
sure,
expansion,
yeah.
but then I will recross in the second diagonal and do a 2O balloon inflation towards the diagonal with a balloon in the main vessel just to protect any stent deformation, any BVS deformation. But I'm not happy of that area where
Let's see.
is
Yeah, so back to your
What
question,
can we
Ajay.
do?
Just because you reach the end of Glagovian remodeling, positive remodeling, it doesn't
Mettiamo
mean the vessel
25.
can't grow more after it's treated. And that's data that goes back a couple of decades. There's a subpopulation that either treated with atherectomy or balloon angioplasty or bare metal stents. They even have more positive remodeling post treatment. And Sujil's point is that if you have BVS-induced positive remodeling, it can extend longitudinally to go to create malapposition at the edges of the adjacent metallic stent. I mean, these are all
Andiamo in craniato,
theoretical
per
things,
favore.
but
piccolo test.
Qua c'è.
Okay, I
Ancora
think we are
Yeah,
still
let's
in
see.
the BVS, but reasonably distal.
Yeah.
And we are covering the area of interest. Mettiamo in memoria, ready for pullback.
yeah.
To
So you
pullback?
comment, Tadashi,
Okay.
and Gary, feel
I'll let,
free.
I'll let
to say,
Tadashi
yeah?
comment.
Okay.
Here is most distal stent. This stent is very expanded. The lesion is very eccentric, so it looks not round, but lumen is okay, I think.
For a 2.5 is okay. We should,
Here is
It's not,
This
not
is the
okay.
yeah
area.
area.
here is not
Yeah.
so, eh?
Yeah,
There
that
is
area
one
was not
spot is
okay.
not-
Okay.
No,
Yes.
you're right.
Yeah.
Then here become
Here-
bigger.
Yeah, no, I checked this the area.
Small test. So that area
And here
that
is-
you
Yeah.
said is not okay was exactly the area where there was no good balloon expansion.
The point is.
Here it looks pretty good. You
Yeah,
agree,
yeah.
Gary?
Okay.
Yeah,
Nice and round. Look, here is beautiful.
Yeah. In the lumen diameter also more than 3.0.
So I think it's going to look good. What we are going to do, we are doing the left main. We are doing crossing into the diagonal. Then we're going to leave the sheet. I'm going to do next patient because we have to continue with the program, our daily. But I will send someone to Columbus where we have the high
Okay.
pressure non-compliant balloon and bring in 1 hour the balloon here and go back into the LED and post-dilate the
Okay.
spot at 38 atmosphere.
Here is a proximal part of LED.
I will send Charbel. Charbel, you're going to go
You
there.
go. You won the trip to Columbus.
That's right.
You said there's no traffic now. He might get back in time.
Or you might get
Yeah,
back
yeah,
to
there is no traffic
Yeah.
in Milano. There is nobody.
So
Or-
this is the
Yeah, we
left
can
main.
see a
eh?
fire
So,
protection.
was any of this
Yeah, here is
pre-dilated
just,
already,
wait.
Antonio?
A little bit, but
Yeah.
not in the left main.
Because there was a small area that looked like an
These are real
intramural
left
hematoma.
Yeah. I think it's the proximal LED was.
Yeah, but it looked like the
Okay.
most proximal
So-
part. Maybe Tadashi can just show us that little intramural hematoma that,
Yeah, can you show the intramural hematoma, Tadashi?
But do you think it would be too aggressive to go with a 3-0 non-compliant?
I'm a little bit, can you measure
Yeah,
two
to see.
questions, Tadashi? Show, I mean, one request and one question. Show the intramural hematoma of Dr. Mintz pointing in the proximal LED.
Here is the proximal LED.
right there, right at the ostium. A little more proximal, a little more, right there, okay?
Okay.
Here,
At 12 o'clock.
Okay.
12 o'clock.
So the-
Yeah,
There.
just outside that, right, just outside that,
Yeah, the black one.
okay? So it's a dissection down to the
yeah, we can
medius.
see the
Yeah.
dissection.
And so what we are going to do, let's see how the diagonal is, but test. I
not
mean, you
bad.
could make a point to
not
leave
bad.
it like
You
that,
can leave it.
because
It's a very small diagonal.
let's do the left main in the meantime. I think we can remove the
circumflex,
wire
we
from
have
the
to
first
cross the
diagonal,
One question. Can you measure
and
then
we're
the
going to
area
put a
of
wire
under
in the
expansion?
circumflex.
Yeah,
The circumflex
this is the
will be
best.
treated in another session. Let's go caudal. How much time do we still have?
We have about 15
So we
minutes,
have 3
Antonio.
minutes. We're going to go 15.
Yes.
Good. Small test.
Can we see the angio, please, or the screen?
Può far vedere il... Andiamo, let's go into the spider e andiamo con un ingrandimento da 20. Piccolo test. Ok.
Sì, non è malato.
Ok, let's go, ma we can stay this view. No, andiamo in obliquo a destra, scusi. So, for the left main, so the question is, the marker of the stent, I see, do you see the marker of the stent? I think I see it.
Yeah.
It's in the proximal LED, but not at the ostium. Let's take a small film. Vietiamo. So the question is, should we use an 18 BVS and post-dilate proximally with a 4O,
But then we have to treat the circumflex
Yeah.
distally, no? Okay.
or use a 3.5
Science.
or even a 4O
Yeah. Science. Or whatever.
science, whatever. And so what do you think? We have both options.
Does the fact that you have to come back for the cert change
There is
impact
the
your
angle.
decision?
Yeah.
Not really, because I I think on the circle I may have to use meta stents, but if as long as I don't come back tomorrow and I open the struts towards the circumflex, it will be okay.
So there are some IVUS measurement of the left main. I mean, if we can see the IVUS, because it's a really big left main.
I mean, would also be a good idea to treat the circumflex now.
Yeah.
Don't you think?
Yes.
Dr. Colombo, can I ask a question?
Yeah.
You know, I always worry, and I feel for proximal portions of LAD, why don't you use regular DES? Because one of the reasons is distally, maybe the surgeon would need to graft in future, and it's good to get the stent off. But in proximal area, anyway, we don't need any surgical option. So we've had some cases where we stented long LAD with 2 absorbs in the distal portion, and proximal portion always a DES, because that can come back to your left main, give you whatever diameter, whatever expansion you want.
I think your point is well taken, but on the other side, I think the only issue of the BVS is sizing. If we had a 4 millimeter BVS, we would not even spend, because there is no drawback except for sizing. What is the distal left main size?
4.5 was measured.
The distal left main.
Distal left main.
Gary, what do you suggest? You are a wise person.
No, I'm not wise. The older I get, the stupider I am. You know, let's just see what the distal measurement is of the distal left main per second.
So the distal is 4.7.
Yeah. You probably are going to want to post-dilate this easily up to 4. And my guess is the proximal half of the left main is more like 5 to 6. So you're going to have to stop a BVS halfway in the left main, or you can use a routine DES of whatever length you want. That's really, you know, one of the things that I would consider. And given the, you know, the incredibly low restenosis rates of a left main that's not a true bifurcation left main, treated with a conventional DES in a large vessel, it seems to me that that makes as much sense as anything.
Yeah.
I agree.
Okay.
I agree.
So mi dà
Agree.
what length? 18, 18?
Yeah.
Mi dà un Oxience 18, 4. So we go with 18 for
The
all
length,
science.
the IVUS, the length? Okay.
Yeah, we're gonna 18,
18,
just to
okay.
be 18. And then we're gonna do gentle kissing towards the circumflex. And maybe I dilate a little bit of the circumflex.
You can do it once.
Maybe we can place a meta stent on the
Ragulitics,
circumflex.
yeah.
Yeah, just, yeah. 418, 418. But I think it's really, for this diffuse LED, I believe this is a good option. And honestly, I think the same amount of work would have been done for Metastent. The only question is, should we have done rotablation from the very beginning without fussing and testing pre-dilatation and say, come on, diffusely disease LAD, calcific, maybe we should have gone down with IVUS, follow Gas-Pichard old rule, if IVUS doesn't go, rotablate.
Yeah, because it did not cross the IVUS initially.
Let me clean Peter. What do you think, Sushil and Gary?
I mean, you know, it's always interesting when you're, as you're finishing a case, to consider what you would have done differently in hindsight. not because you're being, because it's good to be self-critical and learn from things. And I think you're right. I think that one of the biggest problems with diffuse disease is adequate preparation of the vessel. And it's really hard to predict. I mean, another patient with similar anatomy, what you did could have worked out fine. But the more diffuse disease, the more calcification you have, the more adequate preparation becomes important. And whether you use rotoblader or maybe a cutting balloon or a scoring balloon, I think we probably don't use those enough.
Let's go into cranial.
And to your point, Gary, I think the issue is Antonio is very careful, did pre-dilatation,
Penso che sotto.
and sometimes it's hard to fully assess how well you've done, especially with these stents. And the point you made earlier about that's not an adequate expansion, but
Okay.
sometimes it's hard to see. And then once you get to this point, then you have this massive dissection and hematoma,
Right.
and now you can't go back and rotoblate. So
Right.
I think we are okay.
Sì, questo è sul
Ok.
marker, se vuole
Sì.
fare protruding sul marker.
No. So, okay, we can go. This is a 4-0. We are exactly on the marker. Okay. I think we will not go too high.
No, it's
Because
12.
12 is enough. And we need
Ok, go down.
down. We need a non-compliant balloon because there is a
Yeah,
spot.
yeah, to
Mi dà un
post-dilate.
4-0 non compliante. Yeah. 12. Oh. It's okay. I'm sorry. It's okay. 12-8.
can we see the angio again?
Yeah.
Sì, sì, sì.
Yeah. Can you show? Let me remove the balloon.
Sì, lo tolgo.
So you took the same strategy where you
fai
don't want any
rivedere-
overlap with the metal and the BVS, the same as you did with the BVS?
Yeah. I went kind of abutting. Okay. We'll position this wire later on. It's not. It's not a must.
Insomma, devo toccare
Let's
di-
take a picture. Let's stay in this view, but yeah.
Ok.
But you see this nasty area of under expansion. I hate that.
Vuole passare?
Okay, let's position.
The wire.
So, what do you think of that second diagonal? Should
It has life. It's coming back.
Yeah, it's open. This is a keep it open.
Yeah, I mean, it's open, and I can't think of anything that you're going to do more other than an actual stent in it, which you don't want to do, to keep it open more. So I think almost the smartest thing at this point is to leave the second diagonal alone.
yeah. It's a little bit beaten up this wire,
Yeah.
but it's small test.
Yeah, here's the
This is
area where it's
area of
underexpanded as well.
expansion, Yeah.
I don't want to double, but it's okay. It does. Almost there. Small tester. Okay. Sorry for this, but when you remove these big balloons, you have to really be careful because you have a lot of friction and you remove the other wire. So we need to post-dilate the left main. We need to open towards the circ. We need why we finish the circ, Charbel? Can you go to take a 2.5 very high pressure, 6 balloon to Columbus. There is only the secretary, but you go inside in the lab, you have to take in deflator and balloon, 2.5, 6. Okay, take a taxi, I'll pay for you the
Okay,
taxi.
so
okay?
just so the audience
Round
understand, Dr. Colombo is sending one of his staff to another hospital in Milan to bring back a Swiss balloon that, with the inflation device, that can be inflated to
Okay.
38 atmospheres.
Antonio,
Yeah.
we'd like to
Okay.
stay with you
Thank you.
until
Yeah.
we run out of time, but in case the satellite cuts
Okay.
off, we just want to thank you in advance.
Registro
Okay, let's go to higher.
24, huh?
Okay. Yeah, we are at 24 4 balloon post-dilating. So it has been a real pleasure, and especially to have the opportunity to do this case. I must tell you that I was a little bit nervous because, things can go right, but can also go wrong. And when you treat this diffuse disease, as careful as you can be, there is always amount of uncertainty. And when Sushil, you told me in New York, I really want to see the case, I said, my God, is that good or bad? So I was a little bit trepidant. After many years, I'm not very trepidant anymore, but this morning I was a little bit trepidant.
Antonio,
So
if you're
I'm
trepidant,
happy.
you're trepidant with it as a live case. I think the rest of us would have been scared, doing this in
Siamo
the
incaudati.
comfort of our own lab.
But you have to be careful, walk serene, and follow suggestion. I learned more and more to be not firm and follow suggestions. And so I ask a lot of questions to people.
That's great.
Definitely we
That looks
need
great.
to do some work in the left main is fine. The distal flow in the LED is bright. It's nice. Alaide, I'm going to give the taxi money to Charbel. Can you cross into the circle? Okay.
Bye. Bye to everybody.
So what we're going to do, we cross into the circumflex. I think for the sake of the benefit of the patient, we're going to treat the circumflex.
Okay.
So we get Charbel time to go and bring here the balloon. By the time we are done with the circumflex, the balloon will be here and we finish the LED and the job will be well done.
That's great.
Okay.
Thank you, Antonio.
Thank you.
Gary, Sushil, thank you very much. Thank you.
Thank you very much. It's a wonderful demonstration.